sorry. So we can start. I think we had done this question. So a 26-year-old female presented the gynecologist the history of not ever having menses. For the history, remember we said family history, use of contraceptives, medical history, lifestyle factors, and growth and height. And then suggest two relevant biochemical tests. We said you do the hormonal profile, FSH, LH, estrogen, gonadotrophin, hormone-releasing hormone, and prolactin. So the results were done, and these are the results. Okay, so there. Okay, I want us to interpret together. What is the diagnosis? So FSH, she's not menopause, so we don't use this column. FSH is 98. So regardless of the column you use, it's still high. LH 107, which is still high. Estradiol or estrogen, quite low, very low. Prolactin 10.3, which is normal in all spaces. Normal, prolactin is normal. Okay. What is the diagnosis? Remember, she has a history of 26. She's 26-year-old and she has had no menses. And these are the results. High FSH, high LH, low estrogen. What is the diagnosis? Answers in the chat. Any answers? See, no one has responded. No menses. Ovarian failure. Yes. So we usually call it premature ovarian failure. Okay. Premature ovarian failure. Yes. So one thing about premature ovarian failure is what you have to know is it mimics menopause. Exactly. The hormonal profile of premature ovarian failure mimics menopause. What do I mean by mimicking menopause? FSH increased, LH increased, estrogen reduced. That is the hormonal profile of menopause. Okay? So premature ovarian failure or primary ovarian failure, what happens? The problem is in the glands and not the hypothalamus. That's why we call it primary. If it were in the hypothalamus, it would have been secondary, tertiary. If it were in the pituitary, it would have been secondary. So what happens is the pathophysiology is there's usually follicular depletion. It can either be depletion or dysfunction, so leading to the decreased estrogen. That's why you see the estrogen is low, less than 75. Less than 75, okay? Okay, so that is why the estrogen is low. And what happens when the estrogen is low, the body will have a feedback mechanism to try and increase. So the body is thinking, why is the estrogen low? So what we'll do is, let us increase LH and FSH. So pituitary will secrete more FSH and LH. That's why the levels are very high. So if you were to call it, we'd call it a hypergonadotropic hypogonadism. So hypergonadotropic, meaning that the pituitary is very hyper and the gonads are dysfunctional, they're not working well. So hypergonadotropic hypogonadism. Okay. Yes, I'm seeing a question. So how do you differentiate the two? I'm assuming you're asking, how do you differentiate menopause and premature ovarian failure? So premature ovarian failure is diagnosed in patients who are less than 40 years old. So if you're less than 40 years old and you have a hormonal profile of increased FSH, increased LH, and low estrogen, that is premature ovarian failure. But if you're more than 40 years old, we diagnose menopause. Okay? So I hope you've understood. Yes. So I want you to give me causes of premature ovarian failure that you know of. Yeah. Causes of premature ovarian failure that you know of. What is the purpose of measuring prolactin? So yes, so prolactin, as we've seen here, yeah. Remember when we said the biochemical test, we do prolactin levels. We said high levels may warrant looking for pituitary tumor such as macroprolactinoma. You'll see a question. There's a question we're going to do on prolactin. But basically, you might think that you have maybe a macroprolactinoma. And when you have a macroprolactinoma, it's a tumor, so it will press on the anterior pituitary gland. And you can think of all the hormones produced by the anterior pituitary gland. You expect them to shoot. So that's why you have to measure the prolactin levels. Okay. So yes, I was asking causes of premature ovarian failure. Autoimmune, yes. So autoimmune, you can imagine if you have autoimmune cells like T cells going to attack the ovary, what will happen? They will destroy the ovary. Turner syndrome, very important. Remember we said when we were doing the relevant history, we asked about growth. Remember, Turner is 45XO. So this one will is associated with premature ovarian failure. Another one. Congenital agenesis of the ovary. Yes, that's another one. So that's a congenital malformation. Yes. There's another radiation. Yes. Think about radiation and chemotherapy. So those drugs may actually destroy the ovary. And then there's another syndrome, Fragile X syndrome. Yes, it's also associated with yes, smoking. Yes, I feel like smoking. Even if you're ever in an exam and you have no answer to write, just start with smoking. Smoking covers the whole spectrum. It covers many of the diseases. Smoking is a risk factor of many diseases. Yes. Okay. I'm seeing someone is asking, why are FSH? I'm seeing someone is asking why FSH and LH are high. Okay, let me explain again. Okay, this is I'll dive into physiology a little bit. So, what happens is the hypothalamus will release the gonadotrophin hormone, releasing hormone, isn't it? So this one will stimulate the anterior pituitary gland to release FSH and LH. So this FSH and LH are going to work in the follicles. FSH, we remember, if you can remember, FSH used to stimulate the granulosa cells to produce estrogen. So FSH, granulosa cells, estrogen. LH will stimulate the thicker cells to release progesterone and testosterone, isn't it? So you can imagine you're having primary ovarian failure where your follicles are not producing estrogen. So what will happen? The hypothalamus thinks that the body is not producing estrogen. So what will happen is there'll be a feedback mechanism to produce the gonadotrophin releasing hormone to produce more LH and more FSH to produce, because we said the FSH will work on the granulosa cells to release estrogen. Yeah, so it's a feedback mechanism. Okay, now I have a question for you guys. Assuming this patient had secondary ovarian failure, what values would we expect? So comment on the FSH and the LH and the estrogen. Will they be increased, decreased? Yeah, so right for me, FSH may be increased, LH decreased, yes. So reason, secondary ovarian failure. All low. Yes, all low. So FSH will be low, LH will be low, estrogen will be low. Excellent. So what do we call that? Hypogonadotropic hypogonadism. Okay. Yes. So I hope that's clear. Let's see our answers. Yes. So diagnosis, premature ovarian failure, stroke, primary ovarian insufficiency. Reasons, patient is below 40, as I has explained. So this can't be menopause. Increased FSH and LH levels, decreased estrogen levels. Yes. Discuss 3 clinical features that the patient may present with. Answers in the chat. Clinical features you'd expect in such a patient. So remember, they mimic menopause. So think about, I told you, primary ovarian failure mimics menopause. So think of symptoms of menopause. Hot flashes, yes. Hot flashes, yes. Amenorrhea. Yeah, so the patient came because of amenorrhea. So I don't think amenorrhea would be a good clinical feature, but yes. So, okay, no menses, yes. So the patient came with no menses. So let's think of another one. Hot flashes, irritability, yes. Pelvic pain, it's a stretch. Is pelvic pain a sign of menopause? I doubt. Think of the obvious ones. Think of the obvious ones. Mood changes, yes. You're forgetting vaginal dryness, yes. Night sweats, yes. Comment on the libido. Will this patient's libido be high or low? Low libido, yes. Yes. Let's see the answers. Vaginal dryness, yes. Night sweats, hot flashes, dyspareunia or painful sexual intercourse, headaches, reduced libido. Outline 3 possible causes. I think with this one we are done. Turner syndrome, Fragile X syndrome, autoimmune diseases, and chemotherapy. I hope for primary amenorrhea we are understood. So let's go to growth hormone. A 56-year-old teacher was referred to KNH endocrinology clinic with a history of poor vision. Clinical examination showed that he had a protruding jaw, thick fingers, and greasy skin. The following test was performed. So 75 grams of glucose loaded after baseline plasma glucose determination. At time 0, glucose was 8.5. Plasma growth hormone was 36. And we can see the normal is 0.4 to 10. So this is way high. 60 at time 60, which is 1 hour, 14. Plasma glucose was 14. Growth hormone was 32. At time 120, which is 2 hours, plasma glucose was 10. Growth hormone was 38. So before I even ask the diagnosis, because that's the question that will be asked, you can notice this is an OGTT. Remember the procedure of OGTT? So you do the fasting blood glucose first, then you give 75 grams of glucose, then you measure it hourly or 2 hourly, then you do it. I want to ask you guys, why do you think an OGTT was done? So this one, you have to have some physiology knowledge to remember. Why do you think an OGTT was done? Why didn't they just measure the growth hormone levels, just like the way they measure LH levels? Why was an OGTT done? Let me see. Show the question a bit. Oh, sorry. Yeah, is it clearer? Growth hormone affects insulin. Is it supposed to be vice versa? But no, good guess though. Morning. I don't know what you mean by morning. Morning. What do you mean by morning? Why do you think an OGTT was done before growth hormone levels are taken? Anyone in the chat? Anyone? Growth hormone leads to insulin resistance. Yeah, that's actually true, but that's not the reason we do an OGTT. Yes, growth hormone actually leads to insulin resistance. That's true, but that's not why we do an OGTT. So let me explain. I don't know whether I've heard of the phrase we grow at night. Have you heard of that phrase? Have you heard of that phrase? We grow at night. So it's actually true. I remember I had it when I was young. Growing takes place at night. So what is the reason? So the reason is hypoglycemia, which is low glucose levels, is actually a stimulator of growth hormone. So when you're sleeping, you're not eating. So that's why growth hormone is usually secreted at night when you're asleep, and then it works. It's its various functions, okay? So with that principle, if hypoglycemia is a stimulator of growth hormone, what does hyperglycemia do? So hyperglycemia inhibits growth hormone, okay? Now, with that principle, let's think about it. In this patient, we want to know if, so protruding jaw, thick fingers, and greasy skin, I already have a diagnosis in mind, but I want to confirm it. So what I'll do is I want to measure the growth hormone levels. Because we can't tell the patient to sleep, we do an OGTT, give them glucose. When we give them glucose, we have said hyperglycemia inhibits growth hormone. So when we inhibit growth hormone, now we measure the growth hormone that's there after inhibiting it, okay? So after you see it, it's 36, 32, and 38. So now we can confirm that this person has a high concentration of growth hormone even after inhibition, okay? Make sense? Yes. Now you guys tell me, what is the diagnosis in this patient? In this 56-year-old teacher? Acromegaly. Excellent. Acromegaly. So why not gigantism? Why not gigantism? If I write gigantism, will I get the answer correct? Because of the age. Yes, look at the age. The age is 56. So gigantism occurs yes, in young children before the epiphyseal plates are fused. Excellent. The epiphyseal plates are already fused because of her age. So if so, you have to be very keen in case they bring such a question and they put a 6-year-old, then they have these values and they ask, what is the diagnosis? First one is, you think of gigantism. Yeah. The next question, causes of that acromegaly in this patient. What do you think is the most likely cause? It's acromegaly, yes. Now, causes of acromegaly in this patient. Tumor, first diagnosis, excellent. So I'm not sure whether if you just say tumor, they'd give you, but you can be, yes, the best way you can say a pituitary, or you can say a tumor in the pituitary gland. If you just say that, I'm sure they'd give you. But if you say tumor, I'm not sure, but yes, I think that's correct. So pituitary adenoma, yes. So overstimulated pituitary gland. So by what? So you have to ask yourself, what is overstimulating it? So it is the tumor. So the tumor can overstimulate it. And what else? There's one thing you guys are not telling me. Growth hormone cell adenoma, yes. So any tumor that affects the pituitary gland. There's one thing. Let me give you a hint. Think of a tumor that does not originate from the pituitary gland itself, but causing increase in growth hormone levels. What will we call that? Yes, you can have an hypothalamus tumor. Yes. Yes, excellent. Paraneoplastic syndrome. Yes. Paraneoplastic syndrome. So those are the two conditions we can think of. Let me zoom. So acromegaly, excessive growth hormone reduction, that is true. Pituitary adenoma, somatotropinomas, yes, most likely diagnosis. Meniere's tumor, okay, and then paraneoplastic syndrome, increased secretion of growth hormone releasing hormone, yes. Which test should be done prior to the OGTT? So I've already shown you the answer, but I can explain. Serum insulin-like growth factor, IGF-1 or somatomedin C levels. So normally, when a patient presents with this, you do this test first. Elevated levels, suspect acromegaly, then conduct the OGTT. If they are normal, you rule out acromegaly, okay? That's usually the protocol. Is it clear? This one is insulin-like growth factor, IGF-1, yes. I hope we are clear in growth hormone, so we can move to the next. Yeah. Assessment of adrenal function. Okay. 51-year-old female with, so question mark Cushing syndrome. So these are the results that were done for a 51-year-old female. And the clinician is suspecting Cushing syndrome. Urinary cortisol requested. 24-hour urine volume, 2700. Urine cortisol, 58. 24-hour urinary cortisol, 158. So my question is, does the patient have Cushing's? Does this 51-year-old have Cushing's? It's a yes or no answer. So answers in the chat. Yes. The patient has Cushing's. I'd like to know why. Why does the patient have Cushing's? Isn't the range 27 to 335? How does the patient have Cushing's? Yes, no, the patient does not have Cushing's. Look at the range. 24-hour urinary cortisol was 158, and the reference rate is 27 to 335. So this patient does not have Cushing's. I don't know. Those answering yes. What confused you? So I hope this is clear. So no, it is within range. So that's okay. For those who have been confused, here is the range you're looking at. Okay. Or you're looking at the volume. This patient has polyuria. 24-hour urine volume, 27, it's 2700. Purpose of the urine volume. In this test, in a test you're suspecting Cushing's, it's not relevant really. But yeah, our main focus is cortisol. That is what we are focused on. So for urinary volume, so as we spoke about yesterday, so urinary volume is most likely in diabetes, so maybe diabetes insipidus, diabetes mellitus, yeah, is when you can think of that. But yeah, does the patient have Cushing's? No. Okay. A 32-year-old female presented with a history of general weakness and oral pigmentation. Biochemical results as follows. Let me. No. Yes. These are the biochemical results. So let's interpret with you guys. Sodium, low. Potassium, high. Urea, within normal. Creatinine, normal. SYNAC test. So baseline cortisol was 89. After 30 minutes, 92. After 60 minutes, 90. And we know the response is greater than 550. So, okay, interpret the results. First of all, biochemical derangements in this patient. See the chart. Hyponatremia, hyperkalemia. What else? One more you're forgetting. Comment on the cortisol. Is it high? Is it low? Low cortisol, yes. Okay. I'm seeing that someone was asking me, what is a synaptin test? Okay. Okay, a synaptic test. So let me explain how it's done. So a synaptic test, it's usually the method or the test used to confirm diagnosis of primary adrenal insufficiency. Okay, it's usually the gold standard test. So how it's done, one, you administer ACTH, you administer ACTH. So what is the function of ACTH? What's the function of ACTH? Adrenocorticotropic hormone. What's the function of ACTH? Because you cannot just administer ACTH not knowing what it does. What does ACTH do? Stimulate release of cortisol, yes. So we give them ACTH, so the exogenous ACTH. And then after giving them, we expect a stimulation of cortisol. Then we measure the cortisol levels at 30-minute intervals. So 30 minutes and then 60 minutes. So this was his baseline plasma cortisol before administration of ACTH. 89. Then after 30 minutes, 92. After 60 minutes, 90. And the normal response I've been told should be greater than 550 nanomoles per liter. Okay, so that is the SINAC test for that, for who had, the person who had asked. So if you're to interpret the results, hyponatremia, hyperkalemia, and low plasma cortisol levels. Okay, yeah. Yeah. The next question. What is the likely cause of this? What's the likely cause? Adrenal insufficiency. Yes. Yes. Adrenal insufficiency. That's the most likely cause. Let's see. Primary adrenocortical hypofunction, stroke failure. So primary adrenocortical failure leading to Addison's disease. Yes. The SINAC test, exogenous STH, is used to evaluate the functioning of the adrenal gland, as I've explained how we do the test. Okay. Addison's, yes. Outline other clinical features that may present in this patient. So we already saw the clinical features were general weakness and oral pigmentation. Now I want you to outline other clinical features. Clinical features of primary adrenocortical failure. They're quite a lot. If you're stuck, just say nausea, vomiting, diarrhea. Must, it will be there. Any clinical features? Hypotension, yes. Low BP, hypotension, yes. Weight loss, yes. Fatigue, yes. Any others? Salt craving, yes. Sweating, palpitations, yes. Hypoglycemia. Sweating, obesity. Is obesity a clinical feature? Loss of libido, yes. So I want to give you a quick way of remembering these things without actually cramming these clinical features. I want you to remember your anatomy real quick. The adrenal gland was divided into 3 levels, isn't it? We had the zona glomerulosa, zona fasciculata, and zona reticularis. I usually say GFR to remember it. Like glomerular filtration rate, GFR. Yeah. One thing I was taught by my friend, and I've never forgotten, is they usually say the functions of those layers, they usually say the deeper you go, the sweeter it becomes. That's one thing I want to tell you. So GFR, the deeper you go, the sweeter it becomes. Let me explain. First layer, glomerulosa. Okay, what we are producing 3 things. Number 1, mineralocorticoids. Number 2, glucocorticoids. Number 3, androgens. Mineralocorticoids are the aldosterone. Glucocorticoids is the steroids, is the cortisol. And then the third one is androgens, which is testosterone and estrogen. As I've said, the deeper you go, the sweeter it becomes. So glomerulosa, the first one. Mineralocorticoid, it is salt, okay? So aldosterone. The second layer, fasciculata, F, for sugar. The deeper you go, the sweeter it becomes. Sugar. Sugar is cortisol. And then the third one is androgens, which is sex. Sex is testosterone and estrogen. So how you remember? Salt, sugar, sex. The deeper you go, the sweeter it becomes. With that in mind, first layer, glomerulosa, hypoaldosteronism. So damage is to all the three hormones produced by the adrenal gland. Okay. We'll have hypotension. Why hypotension? Remember the RAS system, renin-angiotensin-aldosterone system. It's used to increase the blood pressure. So if you have decreased aldosterone, you'll have hypotension. Number two, salt craving. First layer is salt. So think of salt craving. Hypercortisolism, weight loss. This is sugar or glucose. Anorexia, fatigue, lethargy, weakness, muscle ache, nausea, vomiting, diarrhea, sugar craving. Remember, sugar craving, hypotension. So for here, think of signs of hypoglycemia. Okay. Then hypoandrogenism, loss of libido, so sex, loss of libido and loss of pubic hair. So think about if you have loss of estrogen and loss of testosterone. So loss of estrogen, as we had said, vaginal dryness, you know, the night sweats, the hot flashes, they're quite a lot. So no need to cram, just understand. And then the last one is in this patient with primary adrenocortical hypofunction, we'll have elevated ACTH. Why? This is a feedback mechanism. The body thinks that these three hormones are not being produced, so it will increase the production of ACTH. Now, this ACTH is now what we have the hyperpigmentation of skin. That's why you see here. We said the 32-year-old female has oral pigmentation. Okay. So I hope you're clear with this. I hope you'll remember this. The deeper you go, the sweeter it becomes. And GFR. Let's go to another one. 15-year-old male suspected Addison's disease. Synacted, stimulation test requested. Baseline 218. Reference is 152 to 794. 30 minutes, 376. 60 minutes, 433. Normal response is 550. Now my question is, identify the diagnosis. Identify the diagnosis in this patient, this 15-year-old male. Does he have Addison's? Okay, let me explain. So Addison's is low cortisol, okay? Addison's is basically low cortisol, and you remember Cushing's is high cortisol, okay? Yes. Let me see the diagnosis in the chat. I'm seeing someone is saying yes, so he has Addison's. One is saying acute adrenal insufficiency, and then someone is saying Cushing's. Cushing's. Cushing's is high cortisol. Is the cortisol above 550? And mind you, the normal response is 550. It can't be Cushing's because look at the baseline, 218. And the reference is still 794. So if it was until like if he had maybe 800 plus, that we'd have said Cushing's. So Cushing's is not. When you say acute adrenal insufficiency, do you mean primary? Or do you mean secondary? Or do you mean tertiary? Oh yeah, let me give you guys a hint. The diagnosis is either primary adrenocortical insufficiency, secondary adrenocortical insufficiency, or tertiary adrenocortical insufficiency. So which one do you think it is? Is it primary, secondary, or tertiary? answers in the chat. Secondary. Yes. So this is secondary adrenal insufficiency. So why? Ask yourself, why? Let's see. Why? So this is because the response to ACTH is normal. Like, look at the response. We started with 30 minutes, 376, 60 minutes, 433. And should be above the 550 mark at the 90-minute interval. So look, if you are to draw a curve, you start with 218 here, 376, 433. If you are to reach the 90-minute, we expect it to be more than 550 at the 90-minute interval. It is taking some time for the anterior pituitary to produce cortisol. Yes, so this is actually the reason for the delayed response. You know, this patient has come with secondary adrenal insufficiency. So we know that the problem is in the anterior pituitary gland. So if it were you, the normal patient with no problem in the anterior pituitary gland, and I give you ACTH, your anterior pituitary gland will, the cortisol response will be very, very high, very, very high. But for this patient, you can imagine they have an issue with ACTH production. So the body is not used to that high level. So it's taking some time to adjust to those levels. That's why you're seeing the levels are not that consistent. So, but they are rising. So that's why the comment here was given was subnormal response. So, so that's the diagnosis. Aya, I want to ask you. Aya, the question. I want you guys to comment on the levels of aldosterone and ACTH if they were taken in this patient before the test. Assume the patient came and you did aldosterone and ACTH levels before giving them ACTH. Let's see. I'm seeing someone is saying aldosterone is not affected. ACTH is low. Perfect response. I thought cortisol is produced by adrenal glands. Yes. Had I said anything different? ACTH is produced by the pituitary. The pituitary gland goes to stimulate the adrenal gland to produce cortisol. So I don't know. Had I said anything different? I don't know. Maybe you can clarify in the chat. But aldosterone is not affected and ACTH is low. Excellent. Aldosterone normal, ACTH decreased. Yes, because they have secondary adrenal insufficiency, you expect the ACTH to be decreased. And why is aldosterone normal? Because why is the aldosterone normal? Because we don't have an issue in the adrenal glands, but the pituitary. Yes. Oh, I've seen the issue. Yeah, here should be. Thank you for the correction. Yeah. Thank you. Okay. How would you differentiate between tertiary and secondary adrenal insufficiency? How would you differentiate between tertiary and secondary insufficiency? So think about where does tertiary adrenal insufficiency affect? And think about where secondary adrenal insufficiency affects. How do you differentiate? Hypothalamus, yes. Tertiary is in the hypothalamus, secondary is in the pituitary, yes. Yeah, now my question is, yes, after knowing that, how do you differentiate them now? What test do you do, or what, yes, how do you, because a patient may come, how will you know that this is tertiary or this is secondary? Which hormone do we measure? Basically, that's the question. Yes, measure corticotropin releasing hormone. Yes, there is no response in tertiary after giving ACTH. There is no response in tertiary after giving ACTH. Do you mean in no response in cortisol production, or? Yes. In tertiary, the problem is with the hypothalamus. So no corticotropin releasing hormone is produced. So ACTH production will be low, and in tertiary, as I was explaining, in tertiary, hypothalamus is affected. So when hypothalamus is affected, corticotropin releasing hormone is affected, which will be low. ACTH will be low, and cortisol will be low. So there'll actually be a response. So the best way is to measure this hormone. I'm seeing a question. I don't understand why aldosterone is normal, yet ACTH is decreased. Doesn't ACTH level affect the adrenal gland response? Yes, but what I want you to understand is, what is the function of ACTH? ACTH stimulates the adrenal gland to produce cortisol. Aldosterone is not stimulated by ACTH. It is actually stimulated by the renin-angiotensin-aldosterone system. Okay? So that's why it will be normal. I hope I've answered your question. Yes, thank you. Okay, so I hope you've understood that. So tertiary adrenal insufficiency, low levels of corticotropin releasing hormone. Yeah. Okay. Yes. Here's another question. The following results are obtained from a 32-year-old female presenting with a headache. Prolactin, 4,019, and the range is 105 to 735. TSH, 0.2, which is quite low, yeah. Total T4, 3.75, low also. Total T3, 0.6, low. Okay. Yeah. Diagnosis. Diagnosis. Let's see on the chart. Hypothyroidism, secondary hypothyroidism. You guys are going for the copper and there's a gold. Tertiary hypothyroidism with a laughing emoji. Hypothyroidism and pituitary tumor. So look at our main derangement. What is our main derangement? It's prolactin. Look at the levels, 4,000, and the range is still 735. Meaning that we have an issue with the prolactin before we have an issue with the, with the TSH, T3, and T4. Okay? So I saw someone, yes, a prolactinoma. Good. So this is a tumor on the prolactin. Sorry, on the prolactin. This is a tumor on the anterior pituitary. So this is our main derangement. We have to look at our main derangement before we look at these others. So now this prolactinoma is what is causing the secondary hypothyroidism that you guys are telling me on the chat. So yes, secondary hypothyroidism is correct, but look at our derangement. It's a prolactinoma. Okay. So you can ask yourself why, how does a prolactinoma cause secondary hypothyroidism? So a prolactinoma is a tumor on the anterior pituitary gland, isn't it? You guys, I'm sure you saw it on an antipatho. Oliver had explained it very well. We have the macro and the micro. I remember he also said that the macro prolactinoma will compress the optic chiasm and patients will have blurry vision and headaches. Most likely the cause of this headache is pain. You know, when you have blurry vision, it comes with headaches. That's the anatopatho side, but let's talk about the clinicum side. So this prolactinoma will compress the anterior pituitary gland. So what will happen is you'll have a spike in other what is it called? The other hormones produced by the anterior pituitary gland, isn't it? Okay. So, is it do you have a spike or do you have a reduction in hormones? Look at the TSH, it's reduced. So you'll have a reduction, not a spike, sorry. A reduction in the TSH. So this TSH is secondary to the prolactinoma pressing to the anterior pituitary gland. So, so that's why you have a low TSH, a low T3, and a low T4. Okay. Yes. So diagnosis. Then the next question they usually ask is, which other tests are necessary to be done in such a patient? I think there's a spike in other hormones. Isn't a tumor supposed to stimulate hormone production? Why the decrease? I think, yes, I also thought that. But yeah, most tumors cause a spike in hormone production. But for this one, as someone has said, the tumor is compressing the anterior pituitary. So that's why there's a suppression in hormone production. That's why the TSH is very low. And if the TSH is low, we expect the thyroid to produce low T3 and T4. So this is just a feedback mechanism. Yeah. So which tests would you do? MRI, yes, that's the standard test. So to identify the extent of the tumor, biochemical tests. Which other biochemical tests will you do? Let me see in the chat. Enzyme test. Quite vague. Okay, let me explain. So the test you'll do, one more answer. TRH. What is TRH? I'm assuming you mean thyroid releasing hormone that stimulates the anterior pituitary. Okay, so basically the test that you're going to do is you do tests for hormones produced by the anterior pituitary gland. So which are ACTH, LH, FSH growth hormone levels. So because you know you have a tumor that is compressing the anterior pituitary gland, so you want to do the tests when you do these tests, you want to see if the levels are okay, or if they are low, or if they are high, so that you do a workup for this patient. Because remember, we have a tumor compressing this gland. Okay. Yes. I hope that's clear. I don't want to start on hyper and hypothyroidism. It's a very long session. I think I'll do that afterwards. In our next session. It's quite a long one and needs a lot of explanation. But other than that, I hope you've understood these ones that we have done today. Any question? Is that one for? Thank you.